Hello, my name is Lance Lacasse. I'm going to be demonstrating a full head-to-toe assessment. With this patient, I would start by vital signs, a Snellen chart, and the exam would begin once I first introduce myself to the patient, noting her general appearance, her gait, coordination, her smile, and noting her vital signs, which in this patient were normal, and her Snellen chart was found to be 20/20. Hello, how are you? My name is Lance. I'm going to be doing an assessment on you. With the patient, you begin from the head to the toe. With this patient, I begin with the hair and the scalp. The hair is blonde. It is strong. I don't note any brittle or weak hair. I don't see any patches of hair loss. She has good hygiene. There is no scaling, no redness. From there, I would go down to the face, ears, and the throat and do inspection. This patient's eyes are midline. She's followed me with her gaze throughout the whole interview process. The skin is pink. I don't see any bruising, any lesions here. The ears are both equal on each side. Her sclera and conjunctiva are normal. In her lower conjunctiva, they're both red. I don't see any discharge, any tearing. I don't see any nasal drainage. The lips and the mouth are moist. There is no cracking. There is no lesions. Going down to the neck, the trachea is midline. And I could begin to palpate, starting with the sinuses, the frontal and the maxillary, noting no pain. The tug test on the ears, noting any pain. And to palpate the thyroid gland, I would have the patient turn away from me. And with both hands, come from behind the patient and palpate just along the sides of the trachea. Have the patient swallow, and you can feel those glands move within your fingers. She has no pain. There is no abnormal masses or lesions. And from then I could go to inspection. Starting with the ears. For an adult, you will pull up and back to assess the inner ear. I am able to see the tympanic membrane. It is pearly. There is no pustules. There is no redness in the external canal. She does not have any pain. I would demonstrate both of those. In a normal exam, I would do both sides. And for the mouth, I would inspect using my light source, open wide. Noting any redness, any areas of exudate. Note her tonsils. The tongue is midline. Teeth, there are no caries noted. In the nose, noting any redness in the turbinates. No deviated septum. And from there, to test the sensory and the ocular portions of the head, nose, throat, mouth, and the eyes, I can begin by assessing the cranial nerves. Starting with cranial nerve 1, which is olfactory. I would have the patient close her eyes. Can you close your eyes, please? And when I'm going to introduce you to two different smells, if you could please identify what the smells are. Starting with this one.
Coffee.
And that is coffee. And a second smell. So second, this one.
Alcohol.
Alcohol is correct. So she does have cranial nerve 1 olfactory intact. Cranial nerve 2, we've already tested her visual acuity using the Snellen chart. That was intact. We could then assess the ocular motor, the trochlear, and the abducens using the 6 cardinal gaze, convergent, and the uncover test. So ma'am, I'm going to ask you to follow this light, not moving your head and just following the light. And you would do the 6 cardinal gazes. Back to midline. She followed without any nystagmus. The perla, I noted that her eyes are equal and reactive to light. For convergence, I would have her follow my light source into midline to her nose and then back out, noting any nystagmus, lid lag, or any abnormalities there. If you could just follow my light source, I'm going to go into your nose and back out. And that was all equal. That was cranial nerve 2, cranial nerve 3, and cranial nerve 6, the abducens. Also, we could do the uncover test. I'm going to have you focus on my hand, and then from there I want you to focus on the wall in front of me or behind me. And you can focus on the wall now. And her eyes do accommodate for the change. With the light source again, you can measure her pupil reaction. When I measure directly on her left pupil, it does react to light. And when I do use the same light source on the same pupil, her right eye does accommodate. Also for the cranial nerves, cranial nerve 5, the trigeminal, you measure the sensory and the motor functions of that nerve. You palpate along the masseter muscles and ask the patient to clench. That is intact. And also for the sensory portion, you ask your patient to close their eyes. Close your eyes. And I'm going to introduce 2 different sources of sensation and ask her to differentiate between the 2. You're going to feel either a light or a sharp pressure. Tell me which one you feel.
Soft.
Soft is correct.
Sharp.
And a sharp is correct. And you would do that on both sides. Finally, the facial. Can you please raise your eyebrows? Puff your cheeks. Okay. And that is the facial nerve. That's cranial nerve 7. Cranial nerve 8 is acoustic. I would ask the patient to look away from me, and I would cover her ear with my thumb, and I would whisper a common phrase or term such as baseball and ask her to repeat it to me.
Baseball.
And that is intact. For glossopharyngeal and vagal, you would ask the patient to say ah, and that would test her gag reflex. Can you open your mouth and say ah, please?
Ah.
That is intact. For vagal is the gag reflex. We're not going to assess that now. For spinal accessory, you would ask the patient to shrug her shoulders. Can you please shrug your shoulders? That's intact. And for hypoglossal, the final cranial nerve 12, you'd ask the patient to open her mouth, stick out her tongue, and move her from side to side. Open your mouth, please. Stick out your tongue, side to side. And that is intact. And that is the sensory and the motor functions of those same areas we have assessed. Also, you could do a Weber and Rhines testing for hearing. And they both can measure bone conduction and air conduction. For the Weber, you strike the tuning fork, and place it on the top of their head, and ask her to tell me when she stops hearing it. Okay? And that is testing bone conduction. For the rind test, you would strike the tuning fork again and place it over the mastoid bone, and then when she stops hearing the sound, you take it off of the bone and place it next to the ear, which she should hear it as well. Tell me when you stop hearing it. And that is showing that ear conduction is greater than bone conduction, which is normal. And for the first test that I did, she should hear the sound on both sides of her ears, which is a normal finding. Okay, moving along to the mouth and the throat. We've already inspected the throat. The trachea is midline. There's no deformities. You can assess the posterior side of the neck along the cervical spine, making sure there's no step down, there's no pain, there's no tenderness. Hers is intact, and that is normal. Okay, moving along, we go to the respiratory portion of the exam. First, you inspect again, noting the rate, the depth, and the use of accessory muscles. This patient is young, athletic, doesn't appear to be in any respiratory distress. No use of accessory muscles with breathing, no audible wheezing. And you move to the palpation portion of the exam. You palpate along the chest, noting any crepitus, any pain, any masses. Move along to the posterior side, noting any pain, any tenderness. And if the patient was in a gown, we could look for any bruising, discoloration, which we don't have that. Finally, you could percuss using tactile fremetus. You basically place the soft side of your hand over the patient's chest and ask them ask them to say 99. Right when you feel me touch, say 99.
99.
You avoid the scapular area, which would give you a bone, a dense feeling instead of a resonance feeling on your hand. And basically that is testing for equal in both sides. If you were not to feel that, that would be an abnormal finding. One other test you can do is the expansion test. You basically have the patient face away from you. Face away from you. All right, and this is called diaphragmatic excursion. Well, or we can do expansion first. You place your hands around the patient's waist and touch your fingers in the back to the midline, and you have the patient take a big deep breath in and out. And you want to feel your fingers move away equally and come back and touch at the midline. Next, we can do diaphragmatic excursion. You have the patient take a big deep breath and hold, and then you would percuss and find the area that is dense, and then you would have the patient fully exhale, again palpating until you found the dense area, and that would give you your diaphragmatic excursion. Athletes and such can have levels above 7, but anything around 7 is normal. Okay. Since the patient's already here, I'm going to go ahead and auscultate using the stethoscope. And you can begin above the scapula areas, get the tops of the lung portions. When you feel my stethoscope touch, you just take a big deep breath into your mouth and out. Okay, if you could turn and face towards me. Doing the same thing. normally in an exam we would have a patient in a gown, and with the female it's hard to get the lower portions of the breath sounds with the breast tissue and not being in a gown. So, but with her auscultation, I did not hear any wheezing, any rhonchi. Everything was equal, and she's obviously in no respiratory distress. Moving along to cardiac, I'm going to have the patient lay back, feet up, and you want to have the patient in a comfortable position. Get the pillow position right and ask her to lay her head all the way back. And you start by measuring the JVP. In this patient, you can see she's young, athletic, and you can see the point of maximal impulse is in the suprasternal notch area, which for this patient is normal. In a patient that you were looking for any sort of vascular compromise or disease, you could assess and measure the JVP. You had the patient turn towards her left, find the point of maximal impulse, and using a straight edge, you would measure from that area and down, and anything less than 3 is a normal finding. Okay, but this person does not have JVP, which is normal. You can, while you're here, assess the carotids. And again, you would have already inspected this patient is in no distress. Skin is warm to touch, it's pink, there is no any areas of discoloration. All of her extremities are warm to touch, starting at the shoulder and moving down using the back of your hand. You would measure both sides, obviously looking for warmth. You would start again here at the upper portions of the leg. This patient's in scrubs, measuring down, checking for warmth, hair growth. She doesn't have any shiny skin, so I know she has good peripheral blood flow. Next, after you've already inspected the chest, you've already palpated that area, you can auscultate. And when you auscultate, you're going to use the 8 to man mnemonic, which is the aortic, pulmonic, Erb's point, tricuspid, and mitral. Using the bell and the diaphragm of the stethoscope. Right along the second intercostal space, just to the side of the sternum. Again, this patient does not have a gown on, so it's difficult to measure all of the points. And you would also be able to measure the point of maximal impulse, which due to this patient's breast tissue, we're not going to measure that today. But that should be found in the midclavicular line, just around the mitral area. Moving on, you could, since you're doing the cardiovascular exam already, you could do pulses, measuring the brachial pulse, the radial, on both sides, coming down. This patient has tennis shoes on. I'm going to remove one very quickly. Dorsalis pedis, posterior tib, and those are intact. Since I'm here as well, we can also measure deep tendon reflexes. Using the practitioner's back of the hand, you place the thumb just over the brachial area of that brachial tendon, and using the hammer, you strike, looking for that brachial area reflexes. Going down to the radial, you support the patient's hand, have her relax, and just above this process here, use the back of the hammer and strike. Okay. Have the patient relax her arm at her side, and you can do the tricep. Looking for that tricep to reflex. Have the patient come off the side of the bed with her legs, relaxing the legs. Again, supporting the back of the knee, and just between this patellar area here, you use the pointy edge of the hammer and you strike. And that would be your knee jerk or your patellar reflex. From there, you could go down to the ankle. Again, you have support the patient's foot, and you slightly dorsiflex that ankle, asking her to relax, and you strike the back of the Achilles. And you get that good jerk there. Okay, perfect. All right. Again, please lay back for me here, and you can move to the abdomen. Inspecting the abdomen, we're not going to have this patient lift up her scrub top, but you inspect for any pulsations, any abnormal swelling, any areas of swelling. You could assess for fluid buildup in the abdomen, which this patient does not have any. She has a flat stomach. After inspecting, you can move to light palpation. And for the purposes of assessment, you want to save most of your palpation after you auscultate. Sometimes you can change the bowel sounds of a patient if you deeply palpate too much in the abdomen. You want to listen for up to a minute if you don't hear any bowel sounds just at first. In all four quadrants. Here you could also assess the femoral arteries right in the iliac crest on both sides again. And then you could go from there to the deep palpation of the abdomen. You can check for Murphy's sign, which is for gallbladder. You deeply cup, you find that last rib, and you cup your fingers over, and you have the patient take a big deep breath in. If the patient were to stop and wince in pain, that would be a positive Murphy sign, which is indicative of a gallbladder, acute gallbladder. Remove the patient's pins and foam, and you could assess deeply in the right lower quadrant for appendicitis. That is rebound tenderness. If you deeply palpate in and let go and it causes more pain, that is rebound tenderness, and that is a clue of what could be appendicitis. Okay, so moving on from the abdomen, we would go to the neurological. You can have the patient stand up. You can actually put your shoe back on. Okay, and you want to have the patient walk on her toes towards the door, and then walk back towards me on your heels. And she did that nicely. Her gait is sturdy. She doesn't have any weakness. She didn't have any trouble doing that exam. Okay, you can have a seat. And I believe that covers the head to toe exam. Do you have any other questions for me? Okay, thank you very much.